So this morning I'm going to be talking about some IBD abstracts that I think are particularly important. So I'm going to highlight some important abstracts from DDW 2023. How do I move forward? There we go. So I have no disclosures. Really, the abstracts I chose from DDW this year are mostly on drugs. As general GI doctors, there's lots of new medications that are now available for IBD patients, and so I wanted to talk about those and kind of familiarize you guys with some of the data behind them. So the first two abstracts I chose are on infliximab. It's an old drug, but in a new way. It's the sub-Q infliximab, which FDA approval was submitted in January. So I'm going to talk about how important this is. I think a lot of us are going to start hearing more about this, where we don't have to have IV infusions and a chair in the infusion center. So sub-Q infliximab will be coming hopefully at the end of this year. New drug therapies, risankizumab or Skyrizi was FDA approved last summer for Crohn's disease. FDA approval will be submitted for ulcerative colitis probably end of this year, and hopefully we'll get it FDA approved next year. Upadacitinib or Rinvoq is FDA approved for both ulcerative colitis and Crohn's. So this is the first JAK kinase inhibitor that's approved oral medication for Crohn's disease. So that's pretty important to know. And ozanimod, Zeposia, which is only FDA approved for ulcerative colitis. And we're looking at the 3-year, an abstract was submitted on what does the data look 3 years out after approval. So the first abstract, switching infliximab to subcutaneous from IV therapy. It's the swimsuit trial. It's a prospective real-world single-center phase 4 interventional study. Phase 4 interventional study just means that they're studying a drug that was already FDA approved and on the market. And this is from Dr. Fraser Cummings. Like I said, in the US, submission for FDA was submitted. Sub-Q infliximab was approved in 2020 by the European Medical Agency for use in IBD. This offers patients greater choice, flexibility, convenience, administering their treatment at home, as well as other potential therapeutic benefits. The study aimed to evaluate the clinical outcomes of patients switching from IV to sub-Q. So IBD patients that were established on IV infliximab, at least 4 doses, were offered the opportunity to switch to sub-Q infliximab. Patients who agreed to switch were followed up every 12 weeks for 24 weeks. Demographics, disease history, blood tests, drug levels, anti-drug antibodies, adverse events were all collected at each visit, and the primary endpoint was the maintenance of clinical status at week 24. A failure to maintain clinical status was defined as an increase in disease activity of the modified Harvey-Bradshaw index, or the SCCAI, of greater than or equal to 3, and or a decline in the IBD patient-reported outcome score of greater than or equal to 4 at any time during the study. So I'm sorry the slide's a little bit, you can't really see it, I apologize for that. But so 204 patients receiving IV infliximab, of which 120 were switched to sub-Q. Some basic demographics: 24 had perianal disease, the median age was 38. The median time of patients leaving their home, going to the infusion center, and coming home was about 180 minutes in this study, which is pretty good compared to what most patients see. 96 participants were on combo therapy. 105 were treated with biosimilars prior to getting the sub-Q infliximab. And the mean standard dosing, it didn't matter if they were on 10 mg per kg or 5 mg per kg. They were all random. They were all put on 120 milligrams sub-Q every other week. So that's how the drug is being given. It's every other week, 120 milligrams sub-Q. So only 11 patients discontinued treatment prior to finishing the study. 75% of the whole cohort reached the primary endpoint of maintaining clinical status at week 24. There was no statistically significant difference in disease activity score or patient-reported outcomes between baseline. Of the 89 patients who had no immunogenicity at baseline, 69 maintained this at week 24. So you can see that if anti-drug antibodies, there was, of those who didn't have immunogenicity before, 81.7% still did not have immunogenicity at the end of the study. Patient satisfaction with the sub-Q was very high. So switching from IV to sub-Q is safe, effective, well accepted with higher drug levels. The majority of the patients with no immunogenicity at baseline maintain this at week 24. So, they also looked at drug levels and they found that it was higher because now they're getting it every other week versus IV every 8 weeks. So they actually found the drug levels to be higher. And there are biosimilar sub-Q as well that have been developed in Europe. So those will be coming. So in terms of cost savings for infusion center, drug costs, this is going to be huge. So this abstract won a poster of distinction. It's by Dr. Bruce Downs from Sinai. So now we talked about, okay, we can switch patients from IV to sub-Q. How about maintaining them on sub-Q? So this was sub-Q infliximab as maintenance therapy for ulcerative colitis. It was a phase 3 randomized placebo-controlled study, results of the Liberty UC study. So as we said, sub-Q infliximab formulation was developed to provide patients with a convenient option for treatment. Previous studies showed efficacy of sub-Q comparable to IV and IBD in rheumatoid arthritis, and this study aimed to demonstrate superiority of sub-Q over placebo in maintenance therapy after IV induction. So in the study, 548 patients were enrolled. They all received IV induction of 5 mg per kg. Among them, 438 patients responded. So of those that responded, they were then randomized at week 10 in a 2-to-1 ratio to receive the sub-Q 120 milligrams every other week, and then versus placebo, and then they were observed for 54 weeks. The rate of clinical remission at week 54 was significantly greater in sub-Q compared to placebo, so 43.2% versus 20%. Clinical response, endoscopic histologic mucosal improvement, and corticosteroid-free remission also showed statistically greater improvement with the sub-Q treatment group compared to placebo treatment group. The drug levels, trough concentrations of infliximab was generally similar between the two groups because everybody got IV induction at first. But after randomization, the trough concentration of the sub-Q group were consistently greater than our target therapeutic concentration of 5. And as you can see, placebo drops off. The anti-drug antibody and neutralizing antibody in the sub-Q group were lower than placebo group at maintenance phase. So sub-Q was more effective than placebo for clinical remission, clinical response, endoscopic histologic mucosal improvement, and corticosteroid-free remission at week 54 in patients with moderate to severely active UC. There were no new safety concerns, and these results demonstrate that sub-Q provides both clinical benefit and convenience. Okay, so now I'm going to switch gears to the newer drugs. This is talking about Skyrizi. So Skyrizi was FDA approved last summer in 2022. It's given an IV induction of 600 milligrams IV every 4 weeks times 3 doses. And then you get 360 milligrams sub-Q at week 12 and then every 8 weeks after that. So if patients didn't respond at week 12, most patients were then taken out of the study. And so what this abstract is showing is if maybe patients won't respond at week 12, maybe they'll respond at week 13 or week 14. So they wanted to see if we just kept patients going on the drug, can we capture some of those patients that initially didn't respond at week 12? So this is from Marla Dubinsky at Mount Sinai. Additional risankizumab treatment is effective in patients with moderate to severely active Crohn's disease who did not achieve a CDAI clinical response with the initial 12-week induction treatment, and this is results of the Advance, Motivate, and Fortify study. So risankizumab is an anti-interleukin-23 monoclonal antibody, which is far more specific than Stelara, which is interleukin-12/23. This is more specific to inflammation, interleukin-23. It's demonstrated efficacy, well tolerated both in induction and maintenance in moderately to severely active Crohn's disease. This is a post hoc analysis of the Advance, Motivate, and Fortify studies, and they evaluated the efficacy and safety of 12 additional weeks of therapy in patients who did not achieve clinical response per the CDAI after an initial 12-week induction. So this is the induction and maintenance study design. In the Advance and Motivate induction studies, patients without clinical response, which is stool frequency, abdominal pain scores, criteria to the initial IV induction at week 12, were re-randomized in a 1-to-1-to-1 to receive sub-Q 180 milligrams or sub-Q 360 milligrams at weeks 12 and 20, or IV risankizumab 1,200 milligrams at week 12, 16, and 20 in a double dummy blinded fashion. Patients achieving stool frequency, abdominal pain score clinical response after 24 weeks of induction then entered the fortified maintenance study to receive the maintenance therapy or placebo every 8 weeks for 52 weeks. This was a post hoc analysis, and I'm just for time's sake, I'm going to go through this. Demographics, there was a total of 242 patients who did not achieve a CDAI clinical response in the first 12 weeks. Those patients were then re-randomized to get either sub-Q or IV. Demographics were the same. After 12 additional weeks of Skyrizi therapy, over half of the patients achieved clinical response. More than a third achieved endoscopic response, and the proportion of patients achieving clinical response and clinical remission were numerically higher with sub-Q dosing. So you don't necessarily need to give them more IV, you just need to get them on the sub-Q. In the maintenance phase, response rates were generally sustained or increased further among patients who continued risankizumab treatment. Rates of treatment emergent adverse events were similar across dose groups. So in conclusion, patients with moderate to severe Crohn's disease who did not achieve a CDAI clinical response following 12 weeks of induction therapy, additional 12 weeks of treatment led to improvements in clinical and endoscopic outcomes up to 52 weeks of maintenance study. It's a well-tolerated drug. It's actually pretty safe. It's got a very good safety profile. So, you know, the point of this for me is just continue those patients on there and see if we can capture them. Okay, so the next drug we're going to talk about is upadacitinib, which say that 10 times, very hard, which is Rinvoq, which I'll probably use for this talk. Rinvoq has been really a game changer in IBD. It has in the studies, most of the patients that went into it had failed multiple biosimilars. And this drug really, anecdotally, has been a lifesaver. It really works really well. So I'm going to talk about, this was from, again, Marla Dubinsky at Sinai, and they looked at corticosteroid discontinuation and clinical outcomes in patients with moderate to severely active Crohn's disease treated with upadacitinib. Just to remind you, it was FDA approved last in 2022 for UC. It was just FDA approved last month for Crohn's. So this is the first oral drug for Crohn's disease that we have available. Xeljanz was never FDA approved for Crohn's, so just a reminder. It's given at 45 milligrams once a day for induction, 12 weeks, and then 30 milligrams for maintenance if they had prior biologic exposure, or 15 milligrams daily for maintenance if they've never been on any other biologic. So corticosteroid is used for induction or remission in Crohn's disease. However, because of side effects, toxicity, low rates of mucosal healing, this is not a long-term not for long-term use. Safety and efficacy of upadacitinib, an oral JAK kinase inhibitor, was evaluated among patients with Crohn's disease receiving Rinvoq with cyclosporin at baseline in a phase 3 clinical trial. So this was a post hoc analysis evaluating the efficacy and safety of Rinvoq among patients with moderate to severe Crohn's disease who received steroids at baseline in the phase 3 clinical trials of the UXL, UXceed induction trials, and then the UEndure maintenance. Patients with moderate to severe Crohn's disease were randomized to 12 weeks induction with 45 milligrams once daily or placebo, and patients who then achieved clinical response went on to re-randomize in the maintenance to either getting 45 milligrams, 30 milligrams, or 15 milligrams or placebo for 52 weeks. They found that a greater percentage of patients were cyclosporin-free with upadacitinib or Rinvoq versus placebo at week 12 of induction and week 52 of maintenance. So greater changes from baseline in mean cyclosporin daily dose were observed with upadacitinib versus placebo at induction week 12. These changes were sustained at maintenance week 52. The proportion of patients who achieved greater than 50% reduction in cyclosporin daily was higher in the upadacitinib group versus placebo at induction week 12 among patients taking cyclosporin at baseline and week 52. Significantly greater proportion of patients were steroid-free, achieved clinical remission, endoscopic response, and endoscopic remission with upadacitinib versus placebo at week 12 of induction and 52 of maintenance. Serious infections, opportunistic infection, and herpes zoster events were numerically higher in the upadacitinib group. So remember, with Rinvoq, you need to give them their Shigella vaccination if they never had it. There is an increased risk of blood clots and MACE, which is major adverse cardiovascular events. But again, you know, you don't want to put patients who have a history of clots or high risk for cardiovascular events on these medications. Also, we don't know what happens during pregnancy. So young women, that's something they need to be counseled on. We don't have data on that yet. So that's something to discuss with your patients. So patients with Crohn's disease taking cyclosporin were able to taper and discontinue their cyclosporin regimen and experience clinical and endoscopic improvements with upadacitinib treatment during the induction and maintenance periods. Okay, so this one is important, this slide, because, you know, in the inpatient side, we all have patients in the hospital with severe Crohn's. They have anti-drug antibodies to infliximab. They're flaring, they've already had their colon out. I mean, worst case scenario, we really don't have anything in the inpatient side. And upadacitinib or Rinvoq, this was an abstract from Dr. Colin Bell at Mount Sinai showing that you can actually get symptom-free starting at day 3 within the first week of induction with this drug. So in the IBD world, we are using this anecdotally. Again, it's not on the label. You can use this in inpatient. I mean, this is something, if there's nothing else you can do, this is a good drug to try. So this looked at Rinvoq therapy, reducing Crohn's disease symptoms within the first week of induction. So I'm gonna go through this quickly because my time's almost up. This was a post hoc analysis looking at the induction and maintenance trials. And what they found was that patients treated with upadacitinib 45 milligrams experienced a significant improvement in daily symptoms compared with placebo patients on starting at day 3. Oh, sorry, I don't know how to go back. We're just gonna go to it because I only have 2 minutes. Patients who received upadacitinib 45 milligrams once daily significantly improved daily symptoms of diarrhea, abdominal pain within the first week of treatment, achieved daily clinical remission faster than placebo-treated patients, providing rapid symptom relief. Okay, so something to think about. Anecdotally, we are using it on the inpatient side as it does work pretty quickly, and you've had patients out of the hospital in 2 days. This is looking now the effects on ulcerative colitis, so the effects of Rinvoq on UC symptom resolution and fatigue normalization in patients with moderate to severely active UC. This is the phase 3 You Achieve and You Accomplish results from Dr. David Rubin. They looked at abdominal pain, bowel urgency, stool frequency, rectal bleeding, fatigue. These are all debilitating symptoms that patients with ulcerative colitis have. The results from 2 phase 3 induction trials and 1 maintenance trial show a significantly and clinically meaningful improvement in these symptoms following induction and maintenance with Rinvoq. So this is the basic demographics of the study, and what it shows is that a higher percentage of patients achieve symptom resolution during induction treatment as early as week 2 with upadacitinib 45 milligrams versus placebo, and sustain that through week 8. The difference was also observed during maintenance treatment among clinical responders starting at week 8 with upadacitinib 15 milligrams, 30 milligrams placebo, and sustained through week 52. So you can see that the 30 milligram dose, you're getting a much higher response because most of those patients in this study had prior biologic experience. So we're really only using 30 milligrams. The 15 milligram is FDA approved. Again, you only want to use that for maintenance if they've never been on any other biologic. Furthermore, the percentage of patients who achieved symptom resolution and fatigue normalization was greater with upadacitinib versus placebo at week 8 of induction and 52 of maintenance. So patients with moderate to severe UC were likely to achieve symptom resolution and normalization of fatigue during induction treatment with upadacitinib, and these benefits were sustained during maintenance. And the last drug is ozanimod, which was FDA approved in 2021 for UC. So it is approved only for UC, not Crohn's disease. You get symptom relief within 2 weeks. This requires more screening. You have to get ophthalmology to do an eye exam. You need an EKG to rule out cardiac abnormalities. It's a dose of 1 milligram POQ day. So this was looking at the 3-year True North open label extension. They're looking at, well, how are these patients doing 3 years out? And what they found of the 131 total patients included in this analysis, 87% went to week 46, 72% went to the open label extension. This is their demographics. And they found that clinical responders achieved endoscopic improvement, histologic response, and mucosal healing at week 46, and that continued to week 94. It was associated with a reduction in mean Mayo endoscopy score of 1 at week 52, and this was sustained through week 94. So in this analysis, it shows that a large portion of clinical responders after 1 year who were randomized to ozanimod for up to 2 years thereafter still maintained response. So long-term ozanimod use may be associated with sustained endoscopic histologic benefits in patients with UC. That's it. Thank you, guys.